Good evening, aspirants. Good evening, sir. So, the topic for today is trauma and burn. It is class 2. And the speaker that we have here is Dr. Avishek Roy, Associate Consultant ICU at Apollo Multispeciality Hospital, Kolkata. Thank you, sir. So, you may take over.
Good evening, everyone. The first class we covered the general trauma concepts like primary, secondary, and tertiary survey, and then we went ahead with discussion about the chest trauma. Just a quick recap of of the important points. That first of all, whenever a patient with trauma comes, we have to evaluate the ABCDE: A for airway, B for breathing, C for circulation, D for disability limitation, and E for exposure control or environment control. And the important points we have to take note of is what is the patient's consciousness, whether to intubate or not, what is the level of breathing, whether to put a chest tube or not, how will you manage hemorrhage. And greater discussion on hemorrhage and hemorrhagic shock was done in the last class. Then we come to the risk assessment of the neurological status by GCS score, and afterwards environmental exposure control, hypothermia management, etc. And then we discussed a lot on chest trauma. So now we'll move ahead with one or two small topics, and then we'll go to larger topics. So today's discussion will be on small topics like fat embolism syndrome and compartment, and then I'll go to in general torso trauma, that is the abdominal trauma, and because chest trauma is covered, and then we'll have a discussion on the brain injury. So quickly I go through the first topic, which is fat embolism syndrome. Very important for any kind of exams, whether be it formal exams or MCQs. So it is the definition wise, it is the phenomena of severe biochemical and mechanical manifestations of multiple fat microemboli in the system. So because of which we have different aura of manifestations. So the basic thing, the systemic manifestation because of fat emboli into the circulation. It is a rare phenomena altogether, but in a trauma setup it is very common, and it is seen mostly in patients who have long bone injury or long bone fracture, especially femur fracture, humerus fracture, tibial fracture, and rarely pelvic injury and trauma can also cause that. So the etiology, obviously, with it is a trauma topic, so etiology is by far the most common. 90% cases would be trauma, and especially long bone trauma. Why? Because long bone have bone marrow. Long bone have a larger amount of marrow, and the marrow is functional in adults as compared to vertebrae and everything. So that's why it is much more common with long bone. Except for traumatic cases, we can also see fat embolism in medical cases like acute pancreatitis, if you give too much amount of total peripheral nutrition or total parenteral nutrition TPN back rapidly to a patient. Sometimes with propofol you can have a fat embolism syndrome, and then you can have in severe some cases of sickle cell anemias and all can also have. But let us stick to our topic. So trauma. The risk factors are mostly long bone fracture trauma. As I said, there are two theories proposed why fat embolism syndrome manifests. One is a biochemical theory, one is the mechanical theory. Now we can easily think that if there is a what happens, what is fat emboli by the way? So if there is a bone fracture, what will happen is, if you can see, there are multiple vessels surrounding the bone marrow, and then suddenly because of the fracture, this cerebral fat within the bone marrow will enter into the circulation, and then from there onwards will have dissemination into the system. That's the basic concept. So very easily we can think, okay, it is a mechanical thing. Because of the microemboli that shower into the system, they will go and they will clog multiple vessels and cause the manifestation. So that is the basis of your mechanical theory. But it is not the most common or the traded complication, or the pathophysiologically wise. What happens is a biochemical thing. After it enters into the circulation, it causes a severe systemic inflammation. There is an increased amounts of TNF alpha protein, IL-6, IL-1, and TNF alpha that is secreted into the system, and because of this severe inflammation, along with inflammation comes vasoconstriction. So because of the vasoconstriction and inflammation, there is increase in the pulmonary arterial pressures, there is increase in the right ventricular pressure, there is clogging of the pulmonary arterial system, and therefore we get the hypoxia, the altered sensorium, you get clots and the vasoconstriction in the brain. So you get cerebral microembolism as well as you get all the skin manifestation. The clinical signs are mainly the triad of hypoxia, skin manifestations like petechial rash, especially in the upper body part, upper torso, and altered sensorium. So these classical three features, if it is present in a patient who has a long bone trauma, usually within 24 to 72 hours, that is classical of fat embolism syndrome. So this is very important to note. Each and everything can be asked in the exam. So 24 to 72 hours is the timeline. It can occur although till 5 days, but it rarely occurs after 7 days. So the peak period is 24 to 72 hours, and the classical trait of hypoxemia, petechial rash, and altered sensorium. The respiratory manifestations can range from mild hypoxia requiring low flow oxygen to severe hypoxia and ARDS like features. Neurologically, they can have altered sensorium, they can also precipitate seizures, and they can also land up in coma. And they have a petechial rash, especially in the upper body part, like this shown in the picture. You have small red kind of rash that is spread in the upper body part, and it can also see it in the conjunctiva. Now, there are scoring systems for diagnosing fat embolism syndrome. Mainly, there are two scoring systems. That is, one is Gard's criteria, one is Kornfeld criteria. What is Gard's criteria? There is major and minor criteria. Very easy to remember. Major criteria is all the three that I have said: hypoxia, altered sensorium, and petechial rash. The minor criteria are multiple, like you can have fever, tachycardia. You have to look at the retina to diagnose microhemorrhages. Then the patients can have jaundice, they can have thrombocytopenia, they can have high inflammation and indicated by high raised ESR, and you can see fat microglobules in the urine. That is one of the previously used diagnostic tests. Nowadays we don't use it. We only judge based on clinical parameters. The other criteria which are also used are Lindekis criteria and Schonfeld. The Schonfeld and the Lindekis are important because it has a PO2 level. Hypoxia, it's categorized as PO2 less than 9.3. In Schonfeld, they have given particular marks, scoring marks to particular symptoms. If you have a petechy, you have the highest marks of 5. You have the chest X-ray, it is 4. I mean, chest X-ray showing bilateral infiltrates, ARDS type or patchy opacification. It can be have fat embolism. And then hypoxia 3, confusion 1, and the rest others are 1, fever, heart rate, tachypnea. If your total score is more than 5, you have a diagnosis of fat embolism syndrome. Again, I am saying it is a clinical diagnosis. You don't need to send a specific lab investigation for diagnosing. Second, another scoring system is the Lindekis. It is as similar as Kornfeld. It has got the criteria for PCO2 as well, along with PO2 criteria. So the Schonfeld is much more better as compared to GARDS. Why? Because GARDS is based on clinical criteria. You have to have hypoxia and respiratory distress to diagnose. But if the patient is not having distress, still the patient can be hypoxic. That's why we need to do an arterial blood gas to diagnose the hypoxia based on PO2 levels. So the Schonfeld diagnosis subclinical fat embolism based on the arterial blood gas. That's why Schonfeld is slightly better as compared to GARDS. So this is the chest X-ray showing bilateral diffuse patchy opacities which is seen in fat embolism, and this is a cerebral, I mean MRI of brain showing a T1 and T2 phases, multiple small, you can see hyper intense lesion around the the ventricle, and along with the third ventricle, the corpus corpus callosum, and some of the subcortical structures as well as the posterior horn of the lateral ventricle. So this is known as the star field appearance or the starry sky appearance of MRI, which is classical of cerebral fat embolism syndrome. Next is we can also look at the retina, because eye is directly connected to brain and eye is the kind of the gateway to look at your brain. If you look at the retina, you can find multiple small coronal spots and you can find some blotch hemorrhages. These are the most common symptoms of retina. I mean findings in retina. Now coming to the treatment is supportive, only supportive care. You have to give adequate analgesia, you have to give oxygen support, you have to give anticoagulation. Very important, these patients are having very high risk of DVT because they have a fractured limb, they are immobilized, so they have a high risk of DVT. So you anticoagulate and just give them supportive care. They generally come out of this syndrome within 2 to 3 days after they are diagnosed. Other than that, there are multiple experimental therapies that have been tried, like steroids, anti-inflammatory agents, statins, even heparin and um, aprotinin has been also been tried, but these are all having no evidence to use. Heparin, someone can ask what is the mechanism. Heparin is shown to stimulate lipoprotein lipase. So imagine that you have five fat microglobules in your serum, and heparin goes and cleaves them, and therefore releases the fat microglobules, breaks them. That is the mechanism of heparin. So heparin theoretically has a advantage or can be used in fat embolism syndrome. Similarly, and protease activities, aprotinin is a protease inhibitor. It degrades the platelet aggregation, so that's why it decreases the biochemical reaction. Again, theoretically can be used. Now, the main thing, next part of the discussion is abdomen and pelvic trauma. Now, this is a huge topic, and to be very frank, questions seldom are asked from this concept. So, I will quickly go through the main important parts that are important for clinical practice, and secondly, for exam purpose, we have to know very basic few things in this concept. So, we'll cover the blunt trauma abdomen, penetrating injury, organ injuries, few pelvic injuries, and compartment syndrome. So abdomen can be divided in four regions: upper abdominal part, thoracoabdominal area. So this is the upper abdomen, anterior thoracoabdominal area. We have the posterior thoracoabdominal area. We have got the two flanks, and we have got the back. Mechanism: it could be blunt trauma, like hit. You can a passenger sitting inside a vehicle, getting crashed into some other vehicle or some truck, heavy vehicle, and getting trauma in the anterior or the posterior or the side part of the back of the abdomen without any penetrating injuries. There can be penetrating injuries as well. Now, it is important to differentiate a penetrating from a perforating injury. Penetrating is when you have an injury that has only entry wound, you don't have an exit wound. Supposedly, someone gets stabbed, so that knife has an entry but it doesn't have an exit. So that's called a penetrating wound. And if you have a entry as well as an exit wound, then it's called as a perforating wound, which is most commonly seen with a gunshot wound. So this is a very basic difference. So blunt trauma abdomen seen in most cases of road traffic accident. Mechanism and multiple. Generally, a person sitting inside a car is generally their abdomen is squeezed between the wheel as well as the seat, or it could be because they are from any other. It could be because of multiple mechanisms are there. I'm not going to the details of mechanisms. So it could be because of direct flow, and many a times it is an indirect injury because people are wearing seat belts, and seat belts are strapped around your neck area and the abdomen. So that can cause seat belt injuries. So the seat belt injuries are classical, and there are few important things to remember about seat belt injuries. And the shearing injuries can cause crush injury, and that can also result in abdominal compartment later on. And it can also be result from decelerating injury. Suddenly, a speeding vehicle coming to a sudden halt, and then that wheel is getting struck on the abdomen, that can also cause injury. It can also be as a result of side injury. Previously in class, we said that during secondary survey, we have to address the ample of a patient. What is ample? Ample stands for allergy, medical history, past medication, past medical history, last meal taken, and event that has led to this accident. So before going in depth about the patient, so if the patient is having a hit, injury, you stabilize, and then you inquire about the history of ample and the speed of the motor vehicle accident, the mechanism of injury, and who else was traveling, how many of injured. So all these things give some clue about what are the things that we're looking at. Seat belt injuries results in injury. It can result in injury to the neck because seat belt is obviously coming from the neck, and then it is going across the abdomen to the slot in the back. So it can cause spinal fracture, flexion distraction injuries at C71 multiple levels. It can cause thoracic rib fracture. In abdomen, it can cause pancreatic injury. Very, very important to remember that pancreatic injury and mesenteric tear are very common in seatbelt injuries. Similarly, if you have steering wheel injury, you can have rib fracture, you can have commotio cordis, that is a blunt trauma to heart, you can have bowel perforation, liver and spleen laceration, etc. But to be very frank, by the time of this kind of patients come, you'll get an ultrasound done or a CT scan done, so you get a full delineation of what injuries you are dealing with. So you don't have to think too much about the mechanism and what are the other injuries, because you get a whole body CT scan and you get an entire idea about what are the injuries present in the patient. Few words about the penetrating injury. It could be because of knife, it could be because of gunshots, and in those cases there is something known as a local wound exploration. We'll come to the details. The shotgun wounds, there is a peculiarity about it that if they are fired from a small distance, like less than 2.7, they cause greater damage because obviously the energy percolated on the body as well as the amount of soot and particles that goes through the body is massive. That's why they cause more damage. But if they are fired from a long shot, they cause less damage. But if it is a updated gunshot or gun use that is in modern era, they can cause havoc damage even from distance. So you have to examine the abdomen. You have to see if there is any local signs that indicate abdominal trauma, any subswelling, any mass-like feeling, organomegaly, free fluid. These are all things you should be looking at. Routine routine digital rectal examination may not be helpful in acute cases, and you have to examine for things like this. This is the Cullen's and the Great Turner sign, the periumbilical site hematoma and a flank hematoma, which is actually described in trauma, but later on came to be described in pancreas as well. Similarly, you can have a splenic laceration, and that can irritate the left side of the diaphragm, and the left side of the diaphragm in turn is innervated by C3, C4, C5, and that can have a referred pain to the left side of the shoulder, and this is known as the Kehr sign, Kehr, Kehr sign. Diagnostic test. Now, very important to focus on this part. What are the diagnostic tests of a blunt trauma abdomen? So, foremost is to understand the focused assessment of sonography in trauma. We can also go for CT scan, and there is something known as the diagnostic peritoneal lavage. In addition, we can also go for X-rays, MRIs. Those are always options. FAST is obviously a revolution in the genre of trauma management. It is a bedside curvilinear probe of the ultrasound that is used to diagnose free fluid within the abdomen. And the areas that we target are 5. 4 in acute in FAST and 5 in EFAST. So 4 areas are hepatorenal pouch of Morrison, left-sided splenic creases, then you have the suprapubic creases, and in other than these 3 areas, we have and the epigastrium obviously. And other than these 4 areas, if you are looking at the costophrenic angle, basically looking at the chest to diagnose pneumothorax or hemothorax, then it is called as the EFAST, extended FAST. So EFAST is when you have FAST of the abdomen plus the thorax. This is the very basic thing to understand. Now, in ultrasound, we are looking at free fluid. So it is able to diagnose a hemoperitoneum. If you have an acute free fluid, diagnosis of hemoperitoneum is made. Patient has to be taken to the OT for operation. That's the most underlying meaning. But what are the limitations? So imagine you are doing an ultrasound on a patient to find out fluid in the abdomen. If you have a hollow viscous perforation, you might not get fluid. So it is unable to diagnose hollow viscous perforation or diaphragmatic tears. Secondly, sometimes it could be limited by the the dressing or the patient's attires, etc. And it takes time for the fluid or the blood to accumulate. So if you have a small amount of fluid or blood, it might not get detected. And in patients with pre-existing ascites, and supposedly a patient is known case of CLD with ascites, you will not be able to identify whether it is a new onset blood or the old ascites that is masquerading as a fast positive lesion. And ultrasound is only able to penetrate till before the retroperitoneal. So if you have a retroperitoneal structure, it is unable to pick out. So studies suggest that the lack of bladder distension is a major reason that the pelvic free fluid is missed, and therefore if you want to diagnose pelvic pathologies, you have to inflate the bladder or inflate the bladder with some saline so that you can visualize. So first, very important to remember that the main limitation is retroperitoneal structures are not seen, and old fluids can be misdiagnosed as new fluids. So in that case, obviously we have to rely on the CT scan. There is a entity known as diagnostic peritoneal lavage. What is this? Now, it is basically putting a catheter inside the abdomen and lavaging the entire intra-abdominal contents and getting the contents out of the abdomen and examining them, whether it is blood, whether it is bowel contents, and whether it is exudative sometimes. So the examination of the intraperitoneal contents by putting a catheter. Now, what are the indications? Indications are very, very few. Number one, we have to understand that in the era of ultrasound and in the era of CT scan, putting a catheter, that too in blind technique, it is not to be recommended. If you are drilling a patient in a non-tertiary setup where you don't have a backup, and your one blunt trauma abdomen comes to you, you don't have time to send the patient to a referral center, then to diagnose whether the patient has any diagnostic, possible abdominal pathology or not, you can do that. In current days practice, this is the only scenario where diagnostic peritoneal lavage is used. So evaluation of hemodynamically unstable patient where your uh, you have a lack of proper care or proper escalation, then only you can do a diagnostic peritoneal lavage. So how to do that? You have to prepare the abdomen, sterile technique. You have to put nasogastric tube and Foley's. It is mandatory. You have to decompress the stomach and the bladder. Mandatory. Otherwise, you cannot do. Then, 2 centimeters below the umbilicus, you have to identify your needle site. Then you can do three things. One is open, semi-open, and closed. What is closed? Closed is just like putting a central line. You put a needle, you thread a guide wire, and then you thread a catheter. If you are unsure about this closed technique, you can use a semi-open technique where you take a small incision, a stab knife incision, then you basically put the needle and then you put the guide wire and then you put the catheter. Or you can completely go to an open technique where you use the scalpel full depth till the fascia, put the guide wire inside the abdomen and then put the catheter. After this, you have to gently aspirate. On aspiration, if you find that there is directly blood is coming, that means there is blood inside the abdomen, and that means it is hemoperitoneum. You have to open the patient. That is, you have to go for laparotomy. But if you see that the blood is not coming, but then you go for some lavage. You instill 1 liter of normal saline or ringer lactate, and then you take the samples out. If you see that on the taken out sample, RBC number is significantly high, like more than 1 lakh per millimeter cube, or the WBC number is more than 500, or you see that bowel contents like food materials, like stool particles are coming out, or there is significant amount of uh, 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 bilious contents are coming out, that means there is a possible or positive DPL. Means DPL is positive, patient most likely has an intra-abdominal pathology, and you have to call a surgeon to get a laparotomy done. That is a diagnostic peritoneal lavage. Again, to highlight, it is done in areas where you don't have availability of appropriate imaging, and you have to manage a patient in an emergency scenarios, hemodynamically unstable patient. So that is one very important thing to remember.